रवि सर, यू आर द को होस्ट, सो आप ही ड्राइव कीजिएगा पीपीटी. बस गिव मी नेक्स्ट 30 seconds
Okay.
and then get back.
ये 700 सर. अरे सर, पापा ने बोला है मैंने कहा ठीक है. नहीं नहीं, वो एक्चुअली में स्कैन ही नहीं हो रहा था, तो ये वाला फिर
एक आप लोग को बात देखनी है अभी, एक बार कर दिया ना मैंने.
हाँ.
अभी
60 मिनट्स का.
Sir, start now, please.
Sir, can we start, sir?
yes.
Already we are. Good evening, sir. Dr. Kivsara and Dr. Inaniya. Thank you so much for sparing time with LKM, sir. And I take this opportunity to introduce Dr. Kivsara, who is a senior physician of Jodhpur, sir, and associated and dietitian, diabetes specialist and physician with Siddhi Nursing Home and Diabetic Center in Jodhpur. So I request you to please, sir, introduce with Dr. Inaniya. Kivsara, sir, please introduce Inaniya, sir.
Thank you very much for your kind words. Good evening, all doctors. Today's topic is the place of dual and triple combination therapy in management of hypertension. The speaker is Dr. Ravi Inaniya. He is a well-known cardiologist of Jodhpur. He has done MD, DM in cardiology and working at Shriram Hospital, Jodhpur. Dr. Inaniya will be giving the lecture on the dual and triple combination of therapy in hypertension. As we all know, hypertension is a disease which has to be controlled very effectively, just in order to prevent the long-term complications of stroke, heart failure, and kidney disease. So we have to control the blood pressure to an optimal level so that we can prevent these complications. So Dr. Inaniya will be giving the insight of this topic. Over to Dr. Inaniya, please.
Sir, Dr. Inaniya, we can start, sir. Please start with slides.
Okay. Am I audible now?
Yes, sir. You are very.
Yes, sir.
Okay. So I think I was not audible in the previous two slides. So
Yes, sir.
to begin with, today's topic is the place of dual and triple therapy for hypertension. As we all know, hypertension is quite prevalent all across the world, and India is slowly becoming the capital of hypertension, like of diabetes. And with the availability of the new drugs, the availability of n number of drugs for hypertension, so there is a great scope of controlling this risk factor of CAD. And the more effectively we control hypertension, the more effectively we reduce the risk of CAD apart from other associated risk factors. So most of our hypertension patients on combination therapy, and around 1/3 of our patients are taking multiple pills, and around 2/3 are taking fixed dose.
Pardon, sir. Just a minute, sir. Your slides are not visible to us.
Now,
Just no.
slides are not there.
Yes, sir. Slides are not visible, sir.
1 second.
Yes, sir. Sir, now visible. Slides are visible now, sir. Ravi, sir.
So as seen in this slide, 43% of patients are on monotherapy and 57 on combination therapy, and around 1/3 of hypertensive patients are on multiple pills, whereas 2/3 are taking fixed dose combinations. So list of common drugs prescribed to the population. So most of these drugs are known to us, like amlodipine, telmisartan, which are the most commonly used drug apart from the beta blockers, AC inhibitors, cilnidipine, and the azilsartan. So the guidelines from European Society of Hypertension for the management of arterial hypertension 2023. The definition of hypertension according to the correspondence of home and ambulatory BP values with office BP. As we all know, in routine, when the systolic is more than 140 and diastolic more than 90, we label is at hypertension, and at least 2 readings should be there to label it as hypertension. The important thing is the home BP mean, which is more than 135 systolic and more than 85 diastolic blood pressure. So as the hypertension stage increases, the risk of cardiovascular diseases increases proportionately. And with the increase in systolic blood pressure as well as diastolic blood risk increases significantly over the period of time, and apart from this, as the age increases. So these are the common drugs used for control of hypertension: AC inhibitors, ARBs, the diuretics, which are weak antihypertensives, CCBs, and beta blockers. In young patients, AC inhibitors and ARBs are the drug of choice wherever indicated. So to start with dual combination therapy in most patients, like the step 1 is to combine AC inhibitors or ARB with CCB or a diuretic. Step 2, the triple combination, where most commonly we use AC inhibitor or ARB with an calcium channel blocker and a diuretic. And step 3 is the addition of further drugs if the BP is not controlled, like true resistant hypertension. It constitutes around 5% of our patients. And if the BP is not controlled, we can add other drugs to control the systolic and the diastolic blood pressure. Beta blockers can be used as monotherapy or at any step of combination therapy. Initial monotherapy is recommended for very high risk patients with high normal BP, very old, frail patients, and low risk patients with stage 1 hypertension, that is less than 150/90. The initial combination therapy, maximal dose monotherapy, it addresses multiple mechanisms for BP control, reduces heterogeneity of BP response to the initial treatment, steeper dose response curve and faster response than with the increasing doses of monotherapy. The cardiovascular events is lower in patients started with initial combination therapy as compared to monotherapy. And apart from this, the combination therapy is associated with better long-term adherence and persistence. As shown in the previous slide, the combination of drugs targeting multiple mechanisms reduces heterogeneity of BP response to the initial treatment, provides steeper dose response, is safe and well tolerated, and easily tolerated by the patients. Initial 2-drug combination therapy, it reduces the BP faster as compared to monotherapy. Patients not controlled with ACE inhibitors, ARB or CCB or diuretic like the triple combination therapy, and it's the CKD stage 1, 2, 3, add spironolactone or other MRA or beta blocker or alpha 1 blocker or a centrally acting agent. If it's patient is CKD stage 4 and 5, add chlorthalidone, beta blocker, alpha 1 blocker or centrally acting agent. And if it is not controlled in the stage 1 to 3, then renal denervation can be considered if the eGFR is more than 40. BP lowering therapy in patients with hypertension and CAD. ACE inhibitors or ARBs are the initial drug of choice with beta blockers. If the patient is having angina, then the dihydropyridines, the calcium channel blockers. Without angina, the other drugs or diuretics can be given. BP lowering drugs in hypertension and heart failure. We can start with ACE inhibitors or ARBs, CCBs, MRAs, diuretics, which forms the initial treatment, or it may be the maintenance treatment in many patients with hypertension, beta blockers and SGLT2 inhibitors. BP lowering therapy in hypertension and heart failure with preserved ejection fraction. ACE inhibitors, ARB plus CCB or diuretic, and it can be increased to full dose if well tolerated. Consider substitution of RAS inhibitor by ARNI and or use of MRAs. Spironolactone is preferred therapy MRIs, particularly in lower spectrum of heart failure with preserved ejection fraction. Beta blockers can be used at any step in the combination therapy. If the patient is having BP along with atrial fibrillation, then beta blockers forms the initial line of management, and the dose can be increased level or when the symptoms are controlled. In case of acute stroke, if the stroke is hemorrhagic, less than 6 hours from the symptoms onset, BP lowering to less than 140/90 with IV therapy to avoid hematoma expansion. And if more than 6 hours, if SBP is less than 220, a slow and moderate BP reduction with IV therapy over several hours is preferred over intensive lowering to 140/90 to reduce hematoma expansion. If the systolic BP is more than 220, a careful BP lowering to 180 over several hours with IV therapy is preferred to intensive lowering to less than 140/90 for improving functional recovery. If the stroke is ischemic, eligible for IV thrombolysis or mechanical thrombectomy, lower BP to less than 180 by 105, and maintain it for at least the first 24 hours after thrombolysis or mechanical thrombectomy. If the patient is not eligible for IV thrombolysis or mechanical thrombectomy, if the BP is less than 220 by 120, abstain from BP lowering drug during the first 72 hours. If the BP is more than 220 by 120, moderate BP lowering about 15% with IV therapy during the first 24 hours may be considered based on the clinical judgment. Judicious use of ACE inhibitors, ARB, along with diuretic in the stage 1 to 3, and we can add spironolactone or beta blocker centrally acting agent if the patient is having hypertension along with chronic kidney disease. In the stage 4 and 5, if the patient is having resistant hypertension, chlorothalidone can be added along with beta blocker centrally acting agent. And here the ACE inhibitors and ARBs are avoided. Lifestyle modification is the first and foremost component of management of hypertension. It includes weight reduction, proper dietary habits, dietary products which should be encouraged are vegetables, fruits, bean, nuts, seeds, fish, and poultry. Salt substitute to replace sodium chloride. Increase potassium consumption by dietary modification. Recommended except in advanced CKD patients. Daily physical activity is recommended. At least 30 minutes per day and at least 5 days a week is recommended. Sedentary time supplemented with dynamic resistance exercises 2 to 3 times a week. Reduction of alcohol or close to abstinence. Smoking cessation for all smokers. Stress reduction forms the vital component of hypertension management, and it should be controlled via breathing exercises, mindfulness based with exercise, meditation, and yogas. Potassium and BP U-shaped relationship. Adequate potassium intake good for lowering BP, while excessive intake should be avoided. Sodium and blood pressure. Even reducing sodium intake to very low level, as low as 800 milligrams per day, results in significant linear decrease in blood pressure. We should take sodium in optimal doses, and we should not increase the intake of salt as to control hypertension or to avoid the risk of hypertension. The NICE guidelines for the control and management of hypertension. The clinic BP in the diagnosis arm, if it's under 140 by 90, check BP at least every 5 years and more, often if close to 140 by 90. If it is 140 by 90 to 179 119, offer ABPM or investigate for target or organ damage, assess cardiovascular risk factors. And if it's more than 180 to 120, then if no target organ damage, confirm diagnosis by repeated blood pressure monitoring. Consider monitoring using ABPM and home monitoring, and to start with drugs and to check that the drugs are acting appropriately by checking the control of blood pressure. If it's not controlled, we should escalate the dose of hypertension, and wherever indicate, we should not hesitate in using another drug or add-on drug to the ongoing drug, or increase the dose of the ongoing hypertensive drugs with BP targets. Initial treatment is ACE inhibitors and ARBs. The age is less than 55 or not of Black African or African Caribbean family. If its age is 55 or more, CCBs are the first choice. And we should add drugs in the second step, like the diuretics, CCBs. If the age is more than 55, then we should add ACE inhibitors or ARBs wherever indicated. And consider the use of other drugs to optimal control of blood pressure in hypertensive patients. Similarly, the American Association of Family Physicians 2020, if the systolic BP is more than 160 or more than 20 millimeter of mercury above goal, and we should check the diastolic BP is more than 100, and if it's not controlled by monotherapy, then we should add-on drug, or we should switch over to combination therapy, so that the optimal control of blood pressure is taken care of. Strategies for initiating and titrating antihypertensive drugs: start with one drug. We can increase the dose of the drug if the BP is borderline or mildly raised. If the BP is raised significantly, then we should not hesitate in using two drugs or triple drug combinations wherever indicated. Patients living with systolic hypertension, the accomplished trial showed that BP decrease of 5 by 2.2 led to lower rates of microvascular and macrovascular events and cardiovascular and all-cause mortality. AC inhibitors, ARB, should be used in patients with proteinuria with or without diabetes. A meta-analysis showed that AC inhibitors, but not ARBs, reduce the incidence of doubling of the serum creatinine level in patients with diabetes, but they do not affect progression to end-stage renal disease. Recommendations for the treatment of confirmed hypertension in non-pregnant people with diabetes. If the initial BP is less than 150/90, start with one agent. If the BP is more than 150/90, we will start with two agents along with the lifestyle management. Over a period of time, we should check that the drugs which are ongoing to the patient are effective or not. If it's not effective, BP is on the higher side, then we should add another drug to the ongoing drug. These are the few trials showing the use of optimum dose of blood drugs for the control of blood pressure in monotherapy and in combination therapy in various arms of diabetes and CKDs. Summary of evidence from the most recent clinical trials, hypertension and ambulatory, or it showed that ambulatory or 24-hour BP higher predictive value, intensive BP control improves outcomes, and fixed dose combinations, polypills, they are more effective in controlling higher BP, and primary prevention in pregnancy, elderly, and young, clear benefit of BP control has been seen. So the crux is, wherever indicated, if the BP is slightly higher or in the stage 1 hypertension is stage 2, we can use a single drug. And if it is not controlled by a single drug, we should not hesitate in switching to a two drug or triple drug combination therapy. And if the BP is stage 2, stage 3, as a combination fixed dose therapy is more effective as compared to monotherapy or taking a number of pills, which is not practical for our patients to take on daily basis. And to improve the efficacy of our treatment and overall management of our hypertension patient, we should use double drug or triple drug combinations wherever indicated. Thank you.
Thank you so much, sir, Ravi sir. I just request Kivsra sir to summarize the things, and we just thank you so much. Sir, are you there, sir? Am I audible?
Yes, sir. Audible, sir.
Kivsra sir? I think he is busy in somewhere. So thank you so much, Ravi sir, for sparing your time with us, Alchem, and with the team of Alchem.
Thank you.
Thank you so much, sir. Thank you.
Thank you, everybody.
Thank you, everybody. Thank you.
Thank you, sir.